Welcome back, everyone, to a special edition of the ResearchWorks podcast here in Slovenia, EACD 2023. I have the utmost pleasure now to introduce a guest to you, which I'm sure all of you guys know who she is. I've been trying to get her onto the podcast for a little while now, and I finally have her because we'll have her here in person, Professor Roslyn Boyd. Welcome.
Thanks, Dana. It's lovely to be here. I must say we're all really enjoying the face-to-face.
Oh, it's so nice.
So nice.
It's so lovely. I think we've done a few conferences now where it's been virtual, and whilst it got us through those few years, there's just nothing quite like
Not
seeing
the
each
same.
other again.
No.
Yeah. And you're very, very busy at this conference once again. I do see your name on many parts of the schedule. I've been having trouble following the schedule because it's so extensive. There's so much to it. But I'm really interested in talking to you about some of the work you've been presenting, and I know that this work is something that is still to be published. So we've got this great, exciting body of work to come. But this work has been performed by not just yourself, but your whole team at the Queensland Cerebral Palsy and Rehabilitation Research Centre, the University of Queensland, which I did visit not so long ago. It's outstanding. So let's talk a little bit about the REACH study. And I think that's the part I'm just so interested in, because there are so many parts to this, and I know that this is going to influence practice. So tell everyone a little bit about what the REACH study actually is.
Well, the REACH study has been a really important collaboration internationally, actually. So 4 sites in Australia: Brisbane, Sydney, Melbourne and Perth, and also in Ohio in the States.
Wow.
And with collaborators also from Sweden and Italy. So it's been a big team, but actually really, you're right, actually it was trying to answer a clinically important question at that time. Things to remember is we started in 2015.
Wow.
And the premise was, we registered the trial then, and we wanted to recruit 150 babies. We recruited 96, but that was, hard enough because we had fairly specific criteria.
Sure.
We wanted to pick, and with our friends from Sweden, pick babies that were at high risk of cerebral palsy, unilateral cerebral palsy. And at the time, there'd been few studies like Anki Eliasson's on Baby-CIMT versus massage, one small study from Israel comparing the two approaches, Baby-CIMT versus Baby-BIM, but none that's starting at such a young age. We wanted to start as early as possible. So we wanted to use the high risk of CP, absent fidgety low Hine scores as one feature, but also imaging or on cranial ultrasound or MRI that showed a predominantly asymmetric lesion.
Right.
But then we had the problem is how much laterality of their hand skills did they have?
Sure.
And some people were very concerned that you would recruit babies to this study and you'd be doing constraint induced movement therapy. And people at that stage were very concerned, were you going to have an effect on the good hand if you used constraint?
Sure. Okay.
So we then, luckily, with our Swedish friends, they published a paper soon after that, but Sue Greaves, our colleague in Melbourne, knew that the paper was coming, where a 3-point difference on the high or greater was indicative of a potential unilateral cerebral palsy.
Right.
So that's why we came up with that.
Right,
And
okay.
the interesting results are that, in a way, even though we did select all those babies with those range of impairments and features, and I just got the question when I presented our results, in that we still had 16% of babies in each group who end up with no clinical signs of CP at the age of 2.
Wow.
So we had the predominant group with unilateral CP, a small group with bilateral CP, but a small group who didn't have CP.
Wow, isn't that interesting? And I love how you described, I guess, the evolution of where to head, but it was always very topical. And when you say you registered back in 2015, it does seem like a little while ago now, but it really was, it's such a forefront, because we're talking about early detection, and if you're going to detect, you want to intervene.
Yes.
And so that was an important step, wasn't it?
Well, and that was the other big debate we had, and particularly with some of your colleagues from Perth, in that, they wanted to randomised control trial. So they wanted to compare 1 or 2 or have a third arm who got no treatment. But ethically, you can't not intervene. And then if you have a comparison group, what does that look like? Does it look like something else that's really a third treatment? So that's why our study design was a randomised comparison trial, similar to what Leanne and I had done in older children with CP.
Yes.
But but in a way, it sort of makes it a bit more challenging to say, are they different? And you'll see from the results soon that it is similar to the results we found in older children.
Yeah.
But the important thing is that children with cerebral palsy, both groups have benefited in the study.
Yeah.
Both approaches are safe.
Yep.
And they've all had a good outcome.
Yeah.
So, but the analysis gets more complex when you've got this group of babies who ended up with no features of cerebral palsy.
Yeah.
So did we cure them? I'm not sure that we did, but they have very, very subtle, only, they have no features of cerebral palsy at 2 from independent assessment.
Yeah.
But the good news is we have another study, our MRFF study in Australia, where we're looking at school readiness of all the babies from REACH. Game, and another study on neuroprotection, where at the age of 5 we'll be able to comprehensively look at all those children as to whether they, ended up with any CP features, but any other perceptual, motor or cognitive difficulties.
So all your studies have really woven into that really for a really comprehensive approach. Tell me a little bit more about the actual intervention, about the key ingredients. I feel like I learned a lot about what the key ingredients were from you and all the work that your team does. But let's go through them again, because I think that's really important to note and why it's different.
Yes.
Yeah.
I think the key ingredient, which we learned a lot, because really the Baby-CIMT is designed by Anki Larson. We freely attribute her work because and then the Baby-BIM manual has been developed by Sue Grieve and others, Sue Greaves and others. But, we all contributed, but they were sort of the underlying principles. It follows the principles of motor learning. Yeah. Baby-CIMT is very different to what's applied in older children. Yeah. We do not use a rigid cast, and we very specifically say that. And it's activity-based practice. So there's very little manual guidance. It's getting a spontaneous motor activity, stimulating activity for the involved hand with its Baby-CIMT, and using very subtle restraint for the non-involved hand. Okay. But the key elements are really that it's at what level do you start at?
Sure.
Is the baby able to grasp? Are they pre-grasping?
Yes.
Are they able to grasp from the table, or are they refining their grasp?
Yes.
And the level that we commenced the intervention was very important. And we used a hand assessment of infants to do that, to give us an idea of the level of ability. Yeah. And it looks at the ability of each hand and then both hands together. And no other study has actually done that within the development of their intervention. Yeah. So it's not, when we talk about the principles of neuroplasticity from Mersnick or Klein, I mean, it's not about the dose. Everybody carries on about the dose, and that's a big feature I know in the literature. But it's what you do and what level you start at that's appropriate, the just right level. Yes. Not too hard, not too easy. Yes. And is it meaningful, salient to the baby? Are they motivated? Are they paying close attention? Yep. And then it's the properties not only of the activity that you're trying to stimulate, but it's the toy that you're trying to use. Yep. So in constraint, they were unimanual predominantly tasks and activities. Yes. Whereas in Baby-BIM, you're trying to stimulate both hands being involved either sequentially, one after the other, or both hands simultaneously. Yep. And again, it's got to be at the right level. Yep. Is it pre-grasp, grasp, or fine manipulation? Yep. And then the toys have to be appropriate for a bimanual task. I
love that, yeah.
So, all those sort of elements, I think, are the very important ingredients. But I think the other thing that REACH is very good about, when you think about a lot of the other studies being produced, it's not the therapist who's the expert. Yeah, yeah. It's very much geared to the mother delivering the intervention and being the expert, using a coaching model. Yes. And people use that sort of terminology fairly freely.
These days, yes.
But I've just been in Tbilisi in Georgia, where they're part of our EU project, and they sort of said, this is hands-off therapy. We want to know how to do hands-off. Yeah. And I said, well, it's actually about how you relate to the mother. Yes. And if from your first visit, even in assessing the baby, do you do all the handling of the baby? Or I would say to them, let the mother do the handling and you observe to assess. Use a doll to show them how to position the baby, because you're automatically giving the mother more confidence and more ability,
Yes.
that she's the one to
Yes.
drive what the baby's doing.
Yes. Gosh, there's so much gold in there, and I'm trying to grasp all my questions I want to ask you, Ros. Let's go to the hands-off / I guess, coaching. I feel like the way that you've described it is perfect, because as clinicians, we want to be able to observe, and hands-off doesn't mean we're redundant. I sometimes think that there is that misperception that hands-off means we're on the other side of the room, we're not really doing a great deal, we're not using our skills.
No.
We actually are using our skills.
I think that a lot of therapists misconstrue their relationship with the parent.
Yes.
And, I mean, even this week in Cerebral, we saw some very, very impaired babies who had both, at very young age, had very severe quadriplegia, very severe cerebral visual impairment. And just to come in to the hospital for an assessment, the parents are very stressed because their child is not even able to be put down and on assessment, always cries. And I said, and then we did home visits, totally different.
Yeah.
Babies in their own environment,
Sure.
but also the parents more in control, they're more relaxed.
Yep.
So it's giving parents the confidence to show their baby's skills, you know, even as part of the assessment process.
Yep.
But then in the intervention, we have families coming back now to the 5-year outcomes trial, and we have local providers who have these families going for their NDIS plans.
Yes.
And they said these parents know exactly what to do.
Yeah.
They're all over what goals their baby has,
Yeah.
what they're empowered.
Yeah.
But they're also autonomous.
Yes.
They're able to not just say, oh, well, I'm waiting on the therapist to tell me what to do next. And whereas the local providers tell us those who've had hands-on therapy consistently in a rehabilitation setting, they go to the provider and say, I want to sign up for twice a week till they're age 5.
Right.
Yep.
Yeah.
They've got no kind of confidence or independence.
Okay. Yep.
Whereas, you know, and it was interesting having this discussion with the Eastern European therapists because they haven't had a lot of training on motor learning or approaches where you're trying to use the context, the environment, the toys to stimulate what you want.
Yes.
They're reliant on their hands.
Yes. Yeah.
And even I did BOMAR training. It's almost like you have. I used to talk about people having golden hands.
Yeah.
You know,
I remember that.
That was seen as a really great thing.
Yeah.
But in fact, I was lucky when I first trained in London. I had a mentor, someone called Sophie Levitt. And Sophie trained me. She said, from the minute you walk in the room, you don't need to touch that baby. You get the mother to do everything. And that sort of really stuck with me, actually.
Yeah. It's such a shift, isn't it? And you say that absolutely right. I remember that feeling of I wanted to be amazing and I wanted to touch and feel and manipulate and see what that looked like. So I guess the question from there before I ask you more about the results is, how sure are we about these principles of neuroplasticity and motor learning? Every now and then I do hear through the grapevine, usually through interventions that have not even been tested, so they're non-evidence-based, that sort of, I guess, turn the tide and kind of challenge the notions of what our principles of motor learning are in terms of being salient, in terms of being hands-off and child-initiated. But how sure are we about the science, about what it's saying about neuroplasticity and motor learning principles?
I think the evidence is pretty strong now. If you look at the clinical practice guideline on functional therapy, most of the studies that were effective were child active. So I think that is definitely the case. Child must be active. Goal-directed is more effective than non-goal-directed. So that implies that if the child's active, they're not passively guided. And they have to be an active participant in the study. Now, that's good, but it gets more challenging with GMSS 4s and 5s. So it's thinking, well, your goals need to be different and you have to use adaptive equipment or you have to do other things that are going to make the goal achievable. In fact, there was a lovely session this morning with Helen Politaco and Hortensia Gimeno, who you should interview, about the co-op approach. And I think it was good that they kind of talk about you set goals, but you also set clinically meaningful goals that the child has incorporated or the family. But also it's thinking, you know, not only about what you're trying to do, the goal, but also how much the incrementation is.
Yes.
And I think that's where the broad principles of motor learning have been helpful.
Yeah.
I mean, I originally was trained under Roberta Shepherd, so always a great discussion. Someone who inspired me to do paediatric physiotherapy.
Yeah, wow.
But I think it's also about how do children learn? You know, when I was in England, we had families coming from Europe and they still get Voiter therapy in some places. And I'd say, is the baby enjoying it?
Yeah.
And they'd say, well, no, the baby cries quite a lot, I'm afraid. And I'd say, well, do you think they're learning? Maybe not.
Yeah.
So I think those principles of neuroplasticity, not so much dose, actually. I don't think dose is crucial, is salience, meaningful that the baby is paying close attention, they're motivated.
Okay.
The child is active, goal-directed.
Yeah.
I think those features tell you whether it's something successful or not.
And it sounds like in the REACH study is those are all implemented but empowered for parents to be able to carry it out.
Absolutely.
It's not about us.
No. Well, it's about the parents recognising and saying, oh, now what's the next step? What's the next thing that they're going to do?
Great.
And having that autonomy to see that they could start to think, you know, and when we did our LEAP trial in India, there was that great challenge. We still, again, had them in a good situation for practicing their hand skills.
Yep.
Pretty challenging in Calcutta and the countryside.
Oh, my goodness.
We had basic, you know, principles of a small chair with a table, but, you know, they often lived in the slum with not even a floor, let alone a chair. So positioning the baby so they could focus on their hand function, but then the parents picking objects from the environment as toys because they don't have toys.
Great, and it's just tailoring it to that sort of context, I suppose. And I guess that's the power of these motor learning principles too, is that it's not so dependent on having the haves and the have-nots, I suppose.
Absolutely.
You know, we are empowering each person. So I know that the results are still to be published, so I don't want to give too much away, but in terms of a nutshell, what can we look forward to? What can we sort of glean from some of the results you have so far that you can share with us?
I think the important thing is both approaches were safe.
Great.
So even starting Baby-CIMT early was not a problem.
Great.
They did not have any issue with their early manual ability, motor development, even if they had some short periods of constraint.
Yep.
So they're both safe treatments.
Yep.
They were both effective. Some maybe not, we don't know differentially between I think according to their level of ability, it'd be good to do a second analysis according to the level of ability because treatments were effective for moderate to high functioning children. But the low functioning children, it's harder to shift their abilities.
Sure, okay.
And I think that's what we're finding in all our early intervention trials.
Yeah, okay.
You'll need to talk to Kath Benfer because she's about to submit her LEAP trial. But, you know, there's a difference between severity as to the outcome of these early intervention trials.
Okay.
And I think we need to think what we do for the more severe children is different, which is why kind of motor learning approaches that are adapted to the sort of level of ability, but also what the context is and the child being involved.
And like I said, the goals are different.
Absolutely, the goals are different. You know, for therapists, if we can't expect children who are GMSCS 4 and 5 to have the same goals or the same increment.
For sure.
Or potentially even the same treatment because it'll be adaptation of their environment to achieve their goals.
No, that's wonderful. And I think, look, I'll definitely be knocking on your door once this all gets published, which would be fantastic. But that gives such a great taster for it. Thank you for sharing all of that with us. Now, before I let you go, I'm just going to ask a final question because I know you're also talking to a lot of early career researchers whilst you're here. You've certainly been wonderful and influential for me. I've been to your courses, particularly the one that helped me the most is writing grants because that's just a big part of it, and systematic review courses. But from your perspective, you've now mentored and supported so many of us to get through PhDs and to go further from that. What will be your top 3 tips, I suppose, for what you'd encourage us to be doing and how we can make sure that we're fulfilled in our career, but actually making the impact that, we hope to do so with research.
Thank you. Well, I enjoy it. I really enjoy mentoring young people towards their career development. I mean, I didn't do my PhD till I was after 15 years of clinical practice.
Okay.
And I kind of say now, do a PhD, do it early. Don't, it's a training. It's a stepping stone.
That's a good point.
Gives you a process. It's not going to be the Nobel Prize. You don't have to put all your thoughts and energy into that PhD.
Yeah.
It's the first step.
Yep.
I think the other thing is to do it early, because people, particularly as therapists, that people don't really take you seriously until you've got a PhD in the grand scheme of getting grants and getting your own team.
Yeah, true.
I would make sure that you pick a topic that you're really passionate about, but, get good advice about the sort of feasibility of what you're going to do and whether you've got the sample size and the study design. Pick good mentors who are going to be invested in you. Look at their track records of not only getting people through their PhDs, but supporting them and mentoring them into their next careers. Because I think that's very important, because not all mentors are going to be there for you through the whole journey. And I think that's the other tip. You need a mentor. You always need a mentor, actually, no matter what level you're at. And when I was in Melbourne, they actually brought in a new thing, which I thought was really great. You can have a secret mentor. So it didn't have to be your boss. It didn't have to be your supervisor. In fact, it was probably good to have someone a bit independent. Someone who could look independently at what you're doing and you can have a conversation and get honest feedback.
That's actually
really
powerful.
And they said, who should we pick? And they said, pick someone who's where you'd like to be in 5 years. So I picked a professor in medicine who was a woman. And I thought, that'll be great.
That's fantastic. And your point about mentors is so true. I remember that's probably when I started looking at mentors. I don't think we routinely think about that when you become a professional. You kind of just graduate, and if you do a PhD, your supervisor is kind of your automatic mentor. But to have that structured support is really vital, isn't it?
And you need honest feedback because you get very ingrained in your approach.
Of course.
And you think you're always right. But maybe you kind of need some independent opinion, which I think is good. But the other thing I'd say too for all young students and even clinicians going into research, use that time. It's the best time of your life to maximise your track record and publications, because then you want to lead out as you are with your own studies that you're leading. And, you need that behind you to help get your funding. But I would also ride on the coattails of other people until you get that autonomy. And you're going to need a mentorship for some time. I mean, I even have a mentor now. Everybody has mentors, and I think that's a good thing.
That's so wonderful. Ros, thank you so much for sharing all of that. And I know all these things that you've said are true and real because I've lived through them too. So, I mean, I'm on the other side of the country, but that still happens in that way. So, thank you for what you've done for the profession and for your support for so many researchers.
Oh, thank you. Well, I really enjoy what I do. I think I've said to people a few times, there's not one day that I don't enjoy going to work.
Oh, that's great.
And the one thing that inspired me to work in cerebral palsy was actually seeing Roberta Shepherd back in the 80s when I was a student talking about cerebral palsy, and I thought, I'm never going around and have questions to answer. There's always going to be something interesting, and it's got more and more exciting. I think with what we're doing.
Place to be right now, absolutely. Well, thank you once again. Thank you. To all of our listeners, of course, we'll put links for all of this too on our website, researchworks.net. Stay tuned for more about the REACH study. So stay tuned. We'll definitely make sure we interview Ros again all about that. But hope you enjoy the series, and I'll talk to you all again really soon. Bye.